Chapter 2, the neuron action potential and synaptic transmission. All right, here are the action potentials of three different cell types: motor neuron, skeletal muscle, and cardiac myocytes in the cardiac ventricle. Very first thing is look at the arrow. There's resting membrane potential. We mentioned in the previous chapter that motor neurons are about -70 resting, and skeletal and cardiac are around -90. Which one has a greater potassium conductance? Yes, the muscle does. Both skeletal and cardiac. And we know that because the resting membrane potential is closer to the equilibrium potential for potassium in those cells than it is the motor neuron. All right, this illustrates the rapid depolarization. That's the upstroke of the action potential. This shows the rapid repolarization. So we get a depolarization followed by a repolarization. We indicated that on the previous slide. Next, notice the time scales are markedly different. So in this chapter, we're going to discuss aspects of the action potential that relate to the motor nerve and to skeletal muscle. We will leave the cardiac action potential to its own chapter, which of course will be very high yield, as we will discuss when we get to that chapter. So again, what we're going to talk about in this chapter relates most specifically to motor nerves and skeletal muscle. Okay, what we're going to do in this chapter is we're just going to take what we discussed and what we talked about and our understanding from the previous chapter and just keep applying it up and up and up. Now we're going to take those fundamental aspects and put them into a whole nerve. What we're going to talk about are the key things, the high yield things related to the action potential. Now, an action potential is simply a rapid depolarization followed by a repolarization. Repolarization just means it returns to the resting membrane potential. For nerves, it's to conduct the signal to another nerve or tissue. In muscle, this will initiate a contraction. And as we'll talk about, the different cell types of excitable tissue have different duration action potentials. Ion channels, ion channels, ion channels. Well, we have a very important ion channel here in nerve, skeletal muscle. It'll also exist in cardiac muscle. But this is the voltage-gated sodium channel. This is also called a fast sodium channel. This is responsible for the upstroke of the action potential, is this channel. Now let's go back like we discussed in the previous chapter. Voltage-gated ion channel. This is a voltage-gated sodium channel. So the thing that's going to influence it is voltage. We're going to have three states, and we will recap this in subsequent slides. But they're illustrated here. I'm going to go through them very quickly, and then we will recap it and put in some very important points. First thing to notice is the fast sodium channel has two gates, an activation gate, illustrated there, and an inactivation gate. I've highlighted both of those boxes. So the activation gate's on the extracellular side, the inactivation gate's on the intracellular side. Those are the terms we physiologists use, and that's just because we physiologists are simple kind of people, because that's exactly what the gates do, so we call them that. All right? Pharmacology, they're going to call the activation gate the M gate and the inactivation gate the H gate. Now I'll let pharmacology explain to you why they do that. Three conformational states. Start first with closed rest. Notice the conformational state. Activation gate is closed. Inactivation gate is open. So the channel is not activated because the activation gate is closed. Since it's not activated, it's in the resting closed state. Resting closed state. All right, as we indicated, there are two gates and three conformational states. We'll come back to that picture in a moment. The closed state. Again, the activation gate is closed, the inactivation gate is open. Since I have a closed gate, a closed activation gate, sodium conductance is low. So that's our resting state, that's the closed state. Next is the open state. We will transition these fast sodium channels from closed to open by a depolarization. So a depolarization will cause a transition to the open state from the closed state. Now, because it's open and the inactivation gate is open, we have high sodium conductance. When the gates are open, we'll have high permeability for this channel and thus high sodium conductance for this channel. This increase in sodium conductance will precipitate or will cause further depolarization. Hopefully that makes good sense, because sodium only has one direction to go. Previous chapter, it's going to go in. The greater the conductance I have, the more it's going to drive the cell toward equilibrium for sodium. So if I open some sodium channels, sodium fluxes, that causes depolarization. And the more sodium channels I open, the greater and greater the depolarization. Yeah, that's the whole basis of the action potential and the idea of threshold, which we'll discuss in a moment. All right, when we get to enough of these open, we will initiate this positive feedback cycle, which again, as I indicated, we will discuss more when we get to the nerve action potential. Sodium channels will transition to this inactivated state as, notice in different color, as membrane potential becomes positive. All right, the activation gate is open, but the inactivation gate snaps closed. So a fast sodium channel in an inactivated state has an open activation gate, but a closed inactivation gate. Hence the term inactivation gate, because when the inactivation gate closes, the fast sodium channels in the inactivated state. Hopefully that makes good sense. Again, what's going to cause this transition from open to inactivated? Membrane potential becoming positive. Key point. Membrane potential becoming positive. Now, as the cell repolarizes, comes back to resting, the sodium channels will then transition back to the closed state. Once they return back to the closed state, they're ready for another action potential to take place. So we're going to transition from open to inactivated as membrane potential becomes positive. However, once we get back to rest, the fast sodium channel will transition from the inactivated to the closed state. Now it's ready for another action potential. It's ready to be opened again in order to produce another action potential. All right, let's recap that in words. Once the sodium channel inactivates, it cannot go to the open state until it transitions back to the closed state. All right, an important clinical correlate. Let's go back to the idea of hyperkalemia. As the slide illustrates, hyperkalemia depolarizes. Hopefully you remember that. How do I know? How do I know it's going to depolarize? I don't remember hyperkalemia depolarizes. I just remember concentration gradient, because that's so much easier to, I'm not even memorized. I just know it. It's just second nature. So I have elevated extracellular potassium that reduces the concentration gradient. Potassium tends to stay in the cell. It's a positive charge stain, so it depolarizes. Yep, depolarizes. Now, that gets the cell closer to threshold, and thus increases excitability. Now, we also have to remember, though, that if I have hyperkalemia, the cell will remain depolarized because of the hyperkalemia. So in other words, I won't come back to resting membrane potential. Hopefully you see where I'm going with this. The cell doesn't come back to resting membrane potential. what was important for taking the fast sodium channel from the inactivated back to the closed state? You got it, getting back to resting membrane potential. Now, because the cells don't return back to that normal resting membrane potential, some of the fast sodium channels can't transition from inactivated to closed state. Oh, hopefully that makes perfect sense to you. Okay, again, how do I go from inactive to closed? I get back to rest. Well, hyperkalemia is depolarizing, and it keeps it depolarized, so I can't get back to rest. So over time, those fast sodium channels start getting locked in the inactivated state. All right, they get locked in the inactivated state. If I keep fast sodium channels in the inactivated state, it will reduce excitability. Why? Because fast sodium channels cause the upstroke of the action potential. So chronic hyperkalemia is actually going to reduce neuronal excitability. And that's again because the cell remains depolarized because of the hyperkalemia. So I never return back to the resting membrane state, and some fast sodium channels start to get locked in the inactivated state. They can't go from inactivated to closed. And if I can't get back to the closed state, they can't reopen. So if I have fast sodium channels that are inactivating, then neuronal excitability is reduced because they're causing the action potential. All right, now excitable tissue not only has fast sodium channels, which are voltage-gated sodium channels, they also have voltage-gated potassium channels. All right, these are going to be closed at a resting membrane potential, and we don't have to go through all the gates that we did for the fast sodium channel. These are not quite as complex. They will be closed at a resting membrane potential, and a depolarization will open these channels just like it did the fast sodium channel. But notice that I'm not calling it a fast potassium channel. And that's because the kinetics of this channel are not as fast as the sodium. So they're going to open at a slower rate than the fast sodium channel. As we will discuss, these potassium channels cause repolarization of the cell. All right, here's a slide showing an action potential. The upper half of this is the action potential. Notice the time frame. We're only about 5 milliseconds. And the bottom shows the stimulus intensity. Now, we just discussed the idea of subthreshold stimuli. And this slide illustrates subthreshold responses. Notice line blue and line purple. Blue is a given level of stimulus, and it causes a depolarization than a repolarization. Purple is a greater stimulus, and it causes a greater depolarization, but we don't get to threshold, and as a result, we just repolarize. Hence, subthreshold responses, subthreshold stimuli. Notice that the magnitude of the depolarization is related to the strength of the stimulus. Now, the other thing we mentioned was the idea of summation. Well, let's take a blue stimulus and then give it another stimulus before we completely repolarize, and that's what's illustrated by the black line. Notice how we add on to the magnitude of depolarization. So that's what we mean by summation. So subthreshold stimuli can summate. So those are the key characteristics of subthreshold responses. It's directly related to the magnitude of the stimulus, and it can summate. It can summate. Here represents our magical level called threshold. If I get a depolarization to this point, notice we start at -70 and this threshold is, let's just make up a number. Say it's -55. So if I get this cell to -55, it's going to fire an action potential. So that's the threshold. Notice how the summation of the subthreshold stimuli could turn into a full threshold stimulus. So if I summate subthreshold stimuli, I can actually drive it to threshold. Notice that the green stimulus is a higher stimulus, and that's what takes it to threshold. So the green line is an example of a threshold stimulus. All right, let's talk about nerves, skeletal muscle. Let's talk about the idea of an action potential. We'll start first with stimulating the nerve. We have two different types of stimuli. We have a threshold stimulus and a subthreshold stimulus. So let's start with the idea of subthreshold stimulus. Just as its name indicates, this is a stimulus or a stimuli that is applied to a nerve or skeletal muscle, but it doesn't generate an action potential. It doesn't change membrane potential to threshold, hence the term subthreshold stimulus. As I will show you our picture on the next slide, that the level of depolarization associated with a subthreshold stimulus will be proportional to the size of the stimulus. Now, if another stimulus is applied before we get complete repolarization from the previous subthreshold stimulus, this depolarization of the second stimulus adds to the depolarization of the first stimulus. And I'll illustrate that on the next slide. As we alluded to, or as we showed on that previous slide with the figure, a threshold stimulus means that the initial stimulus is strong enough to depolarize the cell to threshold, and as a result, we get an action potential. This action potential means that we open a critical mass of fast sodium channels. That's what threshold represents. Remember, a depolarization opens sodium channels, and as sodium channels open, it causes a further depolarization, which opens more sodium channels, which causes a further depolarization, and that's that positive feedback cycle that we discussed on a previous slide. So threshold represents that we get a critical mass of fast sodium channels opening, that we just turn on this positive feedback cycle, opening sodium channels, increasing conductance, depolarization, opening more sodium channels, further depolarization, etc. So initially, in the upstroke of the action potential, the sodium conductance is very high. And what's the cell going to go toward? Equilibrium potential for sodium, which is plus 70 millivolts. That's your rapid depolarization. Don't forget, as we went through, when membrane potential becomes positive, the sodium channels begin to inactivate, which is going to reduce the sodium conductance. So initially a high sodium conductance, then as membrane potential becomes positive, sodium channels inactivate to reduce conductance. Now, as more channels open, potassium conductance continues to rise. So again, the more channels I open, the greater and greater the conductance. The positive membrane potential, as we indicated, inactivates the fast sodium channels. So now sodium conductance falls, potassium conductance is elevated, the leak channels, and on top of that, more importantly, the voltage-gated potassium channels. So what are we going to drive the cell toward? Equilibrium for potassium. So we're going to have a very high potassium conductance, sodium conductance is low. This is what causes the rapid repolarization. Once the membrane becomes negative, starts getting close to rest, potassium channels begin to close, and the potassium conductance normalizes. Again, the kinetics are slow, so we will see a little bit of a hyperpolarization. This slide recaps what we discussed for conductance of the ions. Okay, in the green, which I've highlighted the box, you can see the voltage. There's our rapid depolarization followed by a repolarization. Notice the depolarization approaches the equilibrium of sodium. because threshold, we get this whopping increase in sodium conductance, opening of the fast sodium channels. However, as membrane potential becomes positive, notice the rapid drop in sodium conductance. So bam, it goes up, and then the channels start to inactivate and that conductance falls. The blue line shows us potassium conductance. Again, these are voltage gated. The depolarization opens them, but their kinetics are slower. Notice how much slower it is before we see a peak in the potassium conductance. But that peak in potassium conductance is occurring when the fast sodium channels are inactivating, so we're rapidly dropping sodium conductance. We have a very high potassium conductance. So notice how membrane potential is quickly moving toward equilibrium at the bottom of the slide, moving toward equilibrium for potassium. Their kinetics are pretty slow, so as a result, we actually go below rest, so we get a little bit of a hyperpolarization, and then ultimately, those channels will close, and we'll return back to our resting conductance of potassium and sodium, and thus resting membrane potential. Okay, let's recap some of the key points. It's a sodium current that is responsible for the upstroke of the action potential. That again are the voltage gated fast sodium channels. Repolarization is going to be driven by the high potassium conductance. Yes, inactivation of sodium channels occurs, but it is not a major contributor. The main contributor is the high potassium conductance as a result of the voltage-gated potassium channels. Action potentials are all or none. This is a key concept for an action potential. It's all or none. You either get to threshold. If you do, you get an action potential. You don't get to threshold, no action potential. It's all or none. You either got it or you don't. That's all there is to it. You either got it or you don't. Action potentials cannot summate. Remember, subthreshold stimuli can summate, but not an action potential. An action potential is just an explosive, rapid depolarization. You can't add on top of that. No summation. This action potential will get regenerated and thus propagated. So we're going to have clusters of fast sodium channels along an axon. And so we get this injection of current, this rapid depolarization, which will get regenerated at the next group or cluster of fast sodium channels. Just try to imagine, a rope or a hose or something like that. And along this hose, we have our clusters of fast sodium channels. So we inject some current, it depolarizes, get an upstroke, get an action potential. Well, that current is enough to cause threshold in this other cluster that's right next to it, which opens the next cluster next to it, etc., etc. And so as a result, that action potential just keeps regenerating itself down the axon and thus gets propagated. And we'll talk about how fast that travels, conduction velocity, in just a moment. So an action potential, it's all or none, can't summate, and it regenerates, thus it propagates. All right, next big point about nerves for USMLE Step 1 are refractory periods. And the first refractory period is shown here, and this is referred to as the absolute refractory period. All right, definition of absolute refractory. Absolute refractory means, I don't care what you do to that nerve, you won't get another action potential. Okay, no stimulus is going to cause an action potential, period. None, not a one. It is absolutely refractory to another stimulus. All right, and the time, the approximate duration of that with respect to the action potential is illustrated on that slide. All right, let's think about what would make a nerve or skeletal muscle or cardiac muscle absolutely refractory. It means it can't get another action potential. Well, this is because fast sodium channels are either in the open, initially they're in the open state, so the very first part of that is in the open state, or they're in the inactivated state. So if I have fast sodium channels in the open or inactivated state, well, then I can't get another action potential. And so that is the cellular mechanism for the absolute refractory period. Again, I cannot get another action potential. Now, another big aspect about this is the absolute refractory determines the maximal frequency of action potentials. All right, frequency of action potentials means how many action potentials per second I can generate. Now, let's think about this. Let's say, and that's pretty close to on this slide, let's say I have a nerve that has an absolute refractory of 1 millisecond. That means the maximum rate I can get this nerve to fire is every 1 milliseconds. So that means I could get 1,000 action potentials per second. Okay, I can get one action potential every 1 millisecond. That's the maximum frequency. So that's 1,000 action potentials per second. Now, let's increase the absolute refractory to 10 milliseconds. Well, if I can only get an action potential every 10 milliseconds, then that means the maximum frequency is 100 per second. Because I can only get another one every 10 milliseconds. So the maximum frequency is 100. So hopefully that makes sense to you why absolute refractory determines maximal frequency. Next type of refractory period is illustrated here. Time frame. This is called the relative refractory. Now, relative refractory means you can get another action potential, but you need a supra-threshold stimulus. So in other words, you need a stimulus much greater than threshold. Mechanism for relative refractory, the elevated potassium conductance. Go back to the conductance figure in your book, and it'll lay over here on this slide very, very nicely. Remember, potassium conductance goes up, but it's slow compared to the sodium, and it's slow to decline. So during the relative refractory period, I have an elevated potassium conductance, and that's why the nerve is relatively refractory, because you're working against that potassium current. And remember, the potassium current is working against an action potential. It's trying to drive the cell in the opposite direction. It's driving the cell toward equilibrium for potassium. So, two refractory periods, absolute and relative, both important to know, and the cellular mechanisms that drive them. All right, as we indicated before, an action potential regenerates and propagates. How fast does it go? What are the things that are going to influence it? How fast it goes is the conduction velocity. Two big players in nerve. Number one, cell diameter. The bigger the diameter, the faster it conducts. The technical reason for that, or the mechanism, relates to the resistance or the electrical resistance. Big neurons, all right, have a big diameter, so they have less internal electrical resistance, and so the action potential conducts faster. If you have a small diameter neuron, it has greater internal electrical resistance, and thus the conduction velocity is less. So, conduction velocity directly related to diameter. Second is myelination. All right, myelination provides an electrical resistance across the cell membrane, which means that the current travels down the axon rather than leaking out of the membrane. And the more insulation, okay, the more insulation, myelination is like insulating a wire. So we are insulating a nerve. So the more insulation I have, the faster it'll conduct. So the greater the myelination, the greater the conduction. Saltatory conduction is a term we give because hopefully you remember that there are breaks in the myelin. Those are called nodes of Ranvier. These nodes of Ranvier are where we have clusters. Now, before I talked about the idea of thinking of a rope or a hose or something with little clusters of fast sodium channels. Well, it turns out these fast sodium channels cluster at the nodes of Ranvier, which are breaks in the myelin. And so this is where we regenerate the action potential, is at the node. So it looks like the electrical current is bouncing from node to node. And that's what saltatory conduction means. Okay? So again, the bigger the diameter, the faster. The more myelination, the faster. Let's think about some nerve classifications out there. Alpha motor neuron is a big diameter, lots of myelin nerve. All right, neuron. And as a result, very rapid conduction. Those fibers associated with pain, that hurts, those are C fibers. C fibers are unmyelinated, small diameter. They conduct slow. They conduct slowly. All right, let's remind ourselves of a little important pathology here. We have some demyelinating diseases. Two demyelinating diseases. These are multiple sclerosis and Guillain-Barré. Ooh, I don't know. Je ne parle pas français. Yeah, that means I don't speak French. But so if I don't say it quite right, Guillain-Barré, I try to make it appropriate. Or you could just say Guillain-Barré. Yeah, no, yeah, okay. All right, these are demyelinating diseases, multiple sclerosis and Guillain-Barré. All right, this loss of myelin results in leakage. So we talked before that the myelin was like an insulator. If I lose that insulator, then current starts going out. The electrical current associated with the ions starts leaking across the membrane, which means I might not get enough current to my cluster of fast sodium channels. And if I don't get it there, I can't regenerate, therefore I can't propagate. So we get a conduction block because not enough current reaches those clusters of fast sodium channels. So if I can't regenerate it, then I can't propagate it. Yeah, these are demyelinating diseases. Now, let's think about something. Multiple sclerosis. You tend to see spasticity, hyperreflexia. Guillain-Barré causes a flaccid paralysis. If they're both demyelinating diseases, how come I have opposite clinical signs? How can I go from hyperreflexia, spasticity of multiple sclerosis to a flaccid paralysis of Guillain-Barré? And I'm doing the same thing. I'm just demyelinating. That very, very important construct in a retail business, like a restaurant. You know, there are 3 keys to a retail business. What are they? Location, location, location. Yeah, those are the keys. Well, you know what? We have the same thing in physiology and medicine. Location, location, location. Multiple sclerosis, location, central nervous system. It is a demyelinating disease of the central nervous system. So what we lose is that descending inhibition on the alpha motor neuron. When we lose that descending inhibition of the alpha motor neuron, it becomes hyperexcitable, hyperreflexia, spasticity. Guillain-Barré, on the other hand, attacks peripheral neurons. So the alpha motor neuron is where I get the conduction block, and thus I get paralysis. Oh yes. Location, location, location. Don't forget that. Don't forget that. It's very important in physiology. Yep, it's important in medicine. Absolutely. It's important in retail businesses. We're not really concerned about retail businesses right at the moment, are we? No. But it's darn important in physiology, which means it's important in medicine. So here's a nice pictorial rendition of we're looking at the alpha motor neuron synapsing onto a skeletal muscle cell. So there's our presynaptic membrane and postsynaptic membrane. This occurs, of course, across a synaptic cleft. Don't forget that postsynaptic membrane here, skeletal muscle, It's also called the sarcolemma. All right, the sarcolemma. Don't forget that term. Don't forget that term. All right, what we're going to talk about here is going to apply to all synaptic transmission, but we're also going to bring in just the points related to the neuromuscular junction. But we can also cover the basis of synaptic transmission. All right, here's the idea. Our action potential that we just discussed, it gets regenerated and propagated. So it's coming racing down this alpha motor neuron, vroom, really very fast conduction, right? Big diameter, a lot of myelin. Whew. It comes ripping down that axon, and it comes to the presynaptic membrane. All right. On the presynaptic membrane, we have voltage-gated calcium channels. So just as we've discussed, what's going to influence them? Voltage. This action potential is a massive depolarization. And so it's going to open these voltage-gated calcium channels. So we lose the fast sodium channels when we get down here to the presynaptic membrane. So the current here gets carried by these voltage-gated calcium channels. This calcium, hopefully you remember back, previous chapter, we have a huge electrochemical gradient for calcium to come in. It wants to take that cell to plus 125. So calcium is going to flux in. This calcium is going to cause vesicular release. These vesicles containing neurotransmitter in the presence of calcium dump their contents. In this example, it's acetylcholine. The alpha motor neuron is a cholinergic neuron. Now, big key point. The amount of neurotransmitter release is directly related to the amount of calcium that enters. So the more calcium that comes in, more acetylcholine I get. And this applies to all nerves. The less calcium comes in, the less acetylcholine I get out. So, big key, presynaptic voltage-gated calcium channels. Big, big key. They are opened by that action potential that came racing down to the presynaptic membrane. All right, what's this acetylcholine going to do? Well, it's going to look for something to bind onto, because what do we have on the sarcolemmal membrane? We have a ligand-gated ion channel. Yep, just basic kind of stuff. Just applying what we know. Ligand-gated ion channel. Now, this has a particular name. This is the nicotinic receptor. N for nicotinic, and the M stands for muscle. So nicotinic muscle. Nicotinic muscle. But bottom line, it's a ligand-gated ion channel. The ligand, acetylcholine. The ions, ligand-gated ion, well, it's non-selective sodium and potassium. Oh, okay, let's stop and think. All right, what's going to happen if it's non-selective? Doesn't care if it's sodium or potassium. Well, what am I going to see? Am I going to see a hyperpolarizing potassium current or a depolarizing sodium current? Let's apply what we've already discussed. Skeletal muscle membrane is about -90 at rest. Equilibrium for potassium is 95. Well, there's not much net force there, is there? Only 5 millivolt net force. Right? Remember, net force was resting minus equilibrium. So there's not a huge net force there for potassium. Sodium, on the other hand, plus 70 millivolts. Rest, minus 90. Wow, that's 160 millivolts. I have 160 millivolt force for sodium. I have a 5 millivolt force for potassium. Which do you think you're going to see, sodium or potassium? Got a lot more voltage, got a lot more zap in that sodium, don't we? Yeah, so we are going to see a depolarization. And that depolarization has a name highlighted in the box. That's the abbreviation, EPP. Stands for end plate potential. So the opening of this ligand-gated ion channel, nicotinic receptor by acetylcholine, will cause a depolarization. Even though it's non-selective, sodium and potassium have a much bigger net force, so I'm going to see the depolarizing sodium current. Now, this end plate potential, this is shown very simplistically. You have to appreciate we have lots of nicotinic receptors there, and a lot more than one vesicle of acetylcholine comes out. So we're going to open multiple nicotinic receptors, which is going to produce multiple EPPs. Think of an EPP as a subthreshold stimulus. Remember that those can summate. So if I get quite a bit of acetylcholine, I'm opening quite a few nicotinic receptors all together. That end plate potential, yep, it's going to take it to threshold. And what we'll see is an action potential in the postsynaptic membrane. So these EPPs will summate. We will get enough current from them that we will take the sarcolemmal membrane to threshold. All right, big key point. Normal physiology. Normal physiology. If you get an action potential in the alpha motor neuron, you get an action potential in the skeletal muscle cell. It's a one-to-one relationship. Action potential alpha motor neuron, action potential skeletal muscle. It's a one-to-one relationship. You release enough acetylcholine, in other words, enough calcium comes in to get enough acetylcholine out, and you have enough available nicotinic receptors that you're going to take the skeletal muscle cell to threshold. So a one-to-one relationship. If there's not a one-to-one relationship, then you know something's wrong. And that's certainly one of the ways you could couch an experimental or a clinical vignette on step 1. So if I get an action potential in an alpha motor neuron and I don't in the skeletal muscle cell, you know you got a problem. You know you got a problem somewhere. All right, we have to turn off the neurotransmitter. As you know, there's got to be some way. We got to shut the thing down. And what shuts down acetylcholine is acetylcholinesterase. So here in cholinergic neurons, we stop synaptic transmission by chemically breaking down the acetylcholine. And again, that's acetylcholinesterase. All right, little pop quiz, something for you to think about. What is the primary mechanism stopping synaptic transmission for noradrenergic neurons? In other words, neurons with norepinephrine. Oh, if you said reuptake, awesome, awesome, awesome. You did well. Yeah, reuptake is the primary mechanism stopping noradrenergic transmission. And that's a key point. We'll talk about it a little bit later in physiology, but it becomes very applicable in pharmacology. All right, for the last part of this chapter, we're going to talk about synaptic transmission, and we're going to utilize the neuromuscular junction to talk about synaptic transmission in general, and also to think about and work with the high yield points that will also relate specifically to the neuromuscular junction. The neuromuscular junction is that synapse between the alpha motor neuron and skeletal muscle fibers. All right. The alpha motor neuron contains in the presynaptic vesicles acetylcholine. All right, continuing on with the idea of cholinergic system. Again, this is acetylcholine. We have neuronal nicotinic receptors. We just talked about nicotinic receptors at the muscle, but we also have nicotinic receptors on neurons. Outside of the central nervous system, the place to look for these on step 1 will be the autonomic ganglion. All right, preganglionic neurons are cholinergic and synapse on nicotinic receptors in the ganglion. And again, this is both parasympathetic and sympathetic. Both branches of the autonomic, the preganglionic neuron is cholinergic and the synapse is a nicotinic neuronal. Next receptors for acetylcholine are the muscarinic receptors. These are G protein coupled receptors. These are in the target tissues innervated by parasympathetic postganglionic neurons. So in other words, muscarinic exists in the heart, for example, or in the gut, or in the airways. It's where those postganglionic neurons are synapsing at the tissue level. Postganglionic parasympathetic. So preganglionic, for both sympathetic and parasympathetic, they're cholinergic neurons. The synapse, the receptor in the ganglion, nicotinic neuronal. Postganglionic parasympathetic have acetylcholine, and this acetylcholine binds to muscarinic receptors, which are G-protein coupled receptors. Most of the postganglionic for the sympathetic are norepinephrine. All right, let's bridge a little bit to pharmacology as it relates to this cholinergic transmission. We'll start first with Botox. Oh, we all know about Botox now, but you know Botox is a deadly, deadly, deadly toxin. It's deadly. It fixes your wrinkles, but don't get too much because it's deadly. Botulinum toxin is a toxin that targets cholinergic neurons. Mechanism for Botox is it destroys, it's an enzyme that destroys docking proteins, or in other words, proteins needed for the fusion and release of synaptic vesicles. Because it attacks cholinergic neurons, that's neuromuscular junction. If I don't get any acetylcholine out, hey, no action potential in the skeletal muscle cell, flaccid paralysis. And that's why this is so deadly. You get just a little bit too much in your bloodstream, gets distributed to your body. It'll shut down those muscles for breathing. Breathing is a good thing. Remember, all muscles of ventilation are skeletal muscle. So if I paralyze skeletal muscle, I can't breathe. That's Botox. It prevents acetylcholine release. It attacks cholinergic neurons. Next is that nasty black widow spider. The venom from the black widow spider is latrotoxin. It's going to kind of go the opposite direction of Botox. What it does is it opens presynaptic calcium channels. Hey, if I open presynaptic calcium channels, that means calcium comes in, releases acetylcholine. So we'll get excess acetylcholine release because of the opening of those presynaptic calcium channels. That's what latrotoxin does. All right, don't forget pesticides, malathion, for example. And there are some therapeutic agents that block acetylcholinesterase. By blocking acetylcholinesterase, that means acetylcholine lasts longer in the synapse. Yeah, exactly. We can't shut the system off. That's what kills those bugs with malathion. Can you remember some therapeutic drugs that work this way? Can you remember some names? Did you say edrophonium? Awesome. Neostigmine? Awesome. Physostigmine? Awesome. Peridostigmine? Awesome. Very good job. Hey, what's that real important difference between neo and physostigmine? Little pharmacology. Real important difference. And don't give me, duration of action, half-life. The big difference between neo and physo crosses the blood-brain barrier, neo doesn't. Ooh, that's a big one. All right, we also have drugs that can block or work on the nicotinic receptor on the muscle. These are non-depolarizing neuromuscular blockers. They inhibit the nicotinic receptor on the muscle. Can you remember any drugs that do that? Oh, I hope so. One of my favorite drug names. Yeah. Oh, you said atracurium. Yeah, you're right, atracurium. But you can't forget one of my favorite drug names. Rocuronium. Rocuronium. Yes, yes, yes. It is a paralytic. Rocuronium, pancuronium, the onium drugs. But how can you not love that drug name? Rocuronium, man. Rock on, dude. There's another way we can work at the neuromuscular junction, and that, well, it just sucks. Yeah, succinylcholine. Succinylcholine initially depolarizes, so it's called a depolarizing neuromuscular blocker. And that's because succinylcholine is very similar to acetylcholine. What it does, gets on that receptor, opens them up, and those channels just stay open, ultimately you get a paralysis because you can never repolarize. But it's very important to distinguish succinylcholine from, say, pancuronium. Okay, pancuronium is a non-depolarizing. The depolarizing agent is succinylcholine. It sucks. All right, some important pathology integration at the neuromuscular junction. Number one, myasthenia gravis, an autoimmune condition. The bottom line is we have antibodies that block the nicotinic muscle receptor. Yeah. So we're blocking that with antibodies. So do you think the patient's going to be kind of weak, or will they have hyperactivity? Yeah, exactly. They're going to be kind of weak. And one of those clinical vignette things you're looking for is a patient, they tend to get fatigued late in the day and they get a droopy eyelid. Yeah, a droopy eyelid. Excellent. What's the drug that we use to diagnose myasthenia gravis? Edrophonium. Excellent. We give a little edrophonium to block acetylcholinesterase, make acetylcholine last longer. That improves the endurance and strength of a patient with myasthenia gravis. And hopefully that makes sense because, hey, I have more acetylcholine around. I have fewer receptors available, but more acetylcholine. That works. It works. Next is Lambert-Eaton syndrome, also known as Eaton-Lambert syndrome. Interesting. Yeah, I've always known it as Lambert-Eaton, but some people call it Eaton-Lambert, so I don't know, one or the other. Bottom line, autoimmune condition, yes, can be part of that paraneoplastic syndrome. Here we're having antibodies created to presynaptic calcium channels. All right, on the skeletal, at the neuromuscular junction, these antibodies are blocking the voltage-gated calcium channels on the presynaptic membrane. Well, if I'm blocking that calcium, that means less calcium coming in, less neurotransmitter release. Oh, once again, these patients are going to tend to be hyporeflexic and weak because I need that calcium to release acetylcholine. All right, for the next part of this chapter, let's talk about synapses between neurons. And again, the basic cellular mechanism we already covered with the neuromuscular junction, but we do have a couple of things that we need to bring in. So here's a nice, beautiful figure of a neuron. Notice the cell body and all those dendrites sprouting out. And then for the axon, we start with the initial segment. There's the axon hillock in the initial segment. There's our myelin sheath, that little opening in between, the nodes of Ranvier. Initial segment, axon hillock region is very important because this is where the action potential begins. We have a whole bunch of fast sodium channels. Now, synapsing onto this neuron, could be on the dendrites or on the cell body, doesn't matter. Notice we got a whole bunch of little synaptic boutons, so and a whole bunch of nerves coming in, synapsing on there. So it's forming synapses. And the bottom line, the way to think about this is, as we just discussed, synaptic transmission is going to cause current in the postsynaptic cell. We talked about it for the muscle. Now it's the same idea here. What kind of current are we talking? What is happening in this postsynaptic cell? And instead of it being skeletal muscle, it's another neuron. And the idea is, do we want to get this cell, this neuron, to threshold or not? The more current we provide, the greater the likelihood of getting enough current to the axon hillock to have a threshold response, or in other words, an action potential. So the more current you fire into that neuron receiving that input, the more likely you are to get an action potential in that neuron. We have two basic responses between these synapses, which we'll discuss on the next slides. The first response is an excitatory postsynaptic potential, EPSP. It's called excitatory because it means the cell is going to be excited. There'll be an overall increase in excitation of the postsynaptic cell. it's more likely to fire an action potential. And hopefully you're not surprised, this is typically the result of increasing sodium conductance. Sodium is depolarizing. Now, important receptors here. Nicotinic muscle, nicotinic neuronal. We discussed these. Ligand-gated ion channels. We discussed this, acetylcholine. We didn't specifically discuss this one, but this is the non-NMDA receptor. Endogenous agonists are glutamate and aspartate, but again, excitatory because of sodium conductance. And the other one we also discussed, NMDA. Endogenous ligands are the excitatory amino acid. It's a non-selective cation channel, and it's the weird one. It's both ligand and voltage gated. Hopefully we recall that discussion. Now, going the other way, the second response. So the other one was excitatory. So now we have inhibitory. Got to go both sides. Inhibitory, excitatory, excitatory, inhibitory. Inhibitory, just as the name implies, the postsynaptic neuron is less likely to fire an action potential. That's what inhibitory means. What's going to be the key ion here? Chloride conductance. Remember, if I increase the conductance to chloride, I'm going to drive that cell toward equilibrium for chloride, which is around minus 76. Hey, if that cell's sitting at minus 76, then it's not going to get to that minus 55 threshold, is it? Nope, it's going to be inhibited. All right, the big ones, that receptors that gate chloride. Number one, GABA. GABA A and GABA C. Endogenous ligand is, of course, GABA, hence the name GABA. All right, quick pharmacology. What are those drugs that interact with GABA? Can you remember? Two class? Oh, very good. Did you say benzodiazepines and barbiturates? Beautiful. Can you think of any benzodiazepines? Like diazepam, chlorazepam? Very good. Barbiturates, can you name some? Phenobarbital, pentobarbital, methohexatol. You got it. Very good. Thiopental. Very good. Very good. Again, inhibitory. And so those drugs that we just mentioned are inhibitory to the central nervous system. They can be used as antidepressants. They can be used as anesthetics. So basically to depress CNS function. You know, you might take some of those benzos if you want to make sure you don't remember that surgery ever. Ugh, yeah. Next is glycine. Glycine, the endogenous ligand, is of course glycine. So this is going to be inhibitory because it's a chloride channel. All right, now let's stop and think. Remind me, where do you find a lot of glycine? Where is glycine as a neurotransmitter key in the body? Where's a big area it's key? I'm not saying it's the only place, but it's an important place. Yeah, if you said ventral horn of the spinal cord, kudos to you. Excellent job. All right, we have a lot of glycine interneurons synapsing on alpha motor neurons. These are inhibitory. Many are often referred to as Renshaw cells. So we have inhibitory interneurons utilizing glycine. They inhibit the alpha motor neuron. Oh, big application of this where you think, did you know where I was going? Did you know where I was going? Were you thinking it? Good job. Tetanus toxin. You got it. You know, tetanus and botulinum toxin, they behave the exact same way. They do the exact same thing. They destroy these proteins that are important for neurotransmitter release. That's what they do, the exact same thing. But again, the clinical manifestations are opposite. Botulinum toxin, flaccid paralysis. Tetanus toxin, just as the name implies, causes skeletal muscle tetanus, like in lockjaw. That muscle is contracted, Jack. I mean, you know, it's lockjaw. Complete opposite clinical scenario. Okay, clinical manifestation. Just like MS and Guillain-Barré, even though mechanism of action is the same. And the reason? Because tetanus attacks these glycinergic interneurons. By preventing glycine release, we're not inhibiting the alpha motor neuron. That's action potentials in the alpha motor neuron, contraction of skeletal muscle. Again, botulinum toxin destroys cholinergic, it attacks cholinergic neurons. Hey, we get no acetylcholine release. I can't contract the muscle. So, location, location, location. All right, I'm just going to briefly mention the idea of electrical synapses. This is direct current from cell to cell. This communication occurs via gap junction. So there's basically an electrical opening, right? There's basically a hole connecting two cells together. That's what a gap junction is. So the electricity just goes right through the hole. So very fast, no synaptic delay. Not really important that we know of at this stage in the central nervous system or peripheral nervous system, but these will be big time important for cardiac tissue and smooth muscles. So we can't forget the idea of electrical synapses. Okay, let's do a quick little recap of things that we discussed. Let's talk about the idea of if we get a clinical vignette and they give us clinical signs like weakness, ataxia, hyporeflexia, or we got a little sensory deficit or paralysis. All of this suggesting decreased neuronal excitability or neuronal conduction. All right, we have to create a differential for every question, right? Every question we get a differential. We're thinking decreased neuronal excitability because they gave us a clinical vignette in which they said that the patient was hyporeflexic, complaining of weakness, there was some level of ataxia. That's a, it's telling us there's decreased neuronal excitability. So what are we thinking? Well, here are the big classes that we discussed. Number one, ion disturbances. So decreased excitability means hypokalemia. Why mechanism hypokalemia? I hope you said because it hyperpolarizes. You got it. Bigger gradient, positive charge leaves, hyperpolarization. Don't forget, chronic hyperkalemia. We lock those fast sodium channels in the inactivated state. And hypercalcemia. How do I remember hypercalcemia? Calcium blocks fast sodium channels. So if I have excess extracellular calcium, I want to block the fast sodium channels, reduce excitability. So those are the ion disturbances that should be showing up on our differential. We could also be thinking about loss of neurons or demyelination, like that would be decreased neuronal excitability. That's Guillain-Barré because it's attacking peripheral nerves. A couple of things we didn't mention, but we're going to throw in high yield for step one. Loss of neurons occurs in amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, where we get loss of the alpha motor neuron. Same thing occurs in aging, in which we have apoptosis of the alpha motor neuron. Now, some drugs, toxins that we mentioned. Oh, yeah, the cane drugs, lidocaine, marcaine, bupivacaine, procaine. Yeah, local anesthetics because they block the fast sodium channels, as does tetrodotoxin and saxitoxin. Next, we could be thinking, well, maybe the problem's at the neuromuscular junction. It could suck, could be a depolarizing neuromuscular blocker, or it could be non-depolarizing. Oh, yeah. You know, rocuronium, rock on, dude. Yeah, rocuronium, pancuronium, all the onium drugs, etricurium. Lambert-Eaton, myasthenia gravis. This is at the neuromuscular junction. Antibodies. Again, Lambert-Eaton, presynaptic calcium channels, myasthenia gravis, antibodies to the nicotinic receptor. And don't forget that Botox. Botox prevents acetylcholine release, flaccid paralysis. Great for getting rid of wrinkles, although no one will be able to see your facial expressions. All right, going the opposite direction. Clinical vignette. Step one, patient is experiencing muscle fasciculations. They have tetany, they have tremors, they have hyperreflexia, spasms, convulsions, paresthesias. You know, odds are they're not going to put all of these in the clinical vignette, but they throw a couple of 3 in here. And we're thinking, okay, increased neuronal excitability conduction. Differential. We're going to put on our differential. What increases the excitability? What increases? Let me think about the ions. Potassium, key, extracellular potassium. What's going to cause hyperexcitability would be a depolarization. That means, of course, hyperkalemia. That's only acute, but acute hyperkalemia. What's that other role of ion? That's calcium. Extracellular calcium blocks fast sodium channels. So if I have a low level of extracellular calcium, then I'm going to increase excitability because I'm going to have less block of fast sodium channels. So that's right there on my differential. Now, it could be a demyelinating. If they said the word demyelinating and they said spasms, hyperreflexia, bam, just jump on it. Multiple sclerosis. Okay, it's demyelinating CNS. Some drugs that will increase the duration of the action potential are our drugs that block inactivation. Ciguatoxin, batrachotoxin, CTX, BTX. Again, they block inactivation, so I have a little bit longer duration action potential. They're not the key player for repolarization. Hopefully you remember potassium. Potassium channel blockers would have a much bigger impact, but both will increase the duration of the action potential. And if I increase the duration of the action potential, I'll get more acetylcholine release. And last but not least, we could work at the neuromuscular junction. We could indirectly activate the receptor by giving acetylcholinesterase inhibitors, neo, physostigmine, edrophonium. Block acetylcholinesterase, acetylcholine lasts longer. And don't forget the black widow, latrotoxin, opens presynaptic calcium channels to cause acetylcholine release. So again, put these things together, but you notice as we worked our way through this chapter and the previous chapter, started with the ion channels and then just build up. Own that base information. Then we can just work with it again and again and again. Very important for doing well on step 1.